Dr. Harton received his Bachelor of Science degree from James Madison University and a PhD from the University of Kent. His thesis title was really a game changer in the field of pre-implantation genetic testing, screening, and diagnosis, and especially because it was focusing on new technology and optimization of that PGT-A field. Dr. Harton is certified by the American Board of Bioanalysis as a technical supervisor in molecular diagnostic, and he is a member of the American Society for Reproductive Medicine, as well as the European Society for Human Reproduction and Embryology. Thank you so much, Gary, for joining us. And the floor is yours.
Well, thank you very much for having me, Nabil. I really appreciate it. I'm going to try not to step on anything that Nabil already spoke about. I do have one slide on non-invasive because I do think it's quite an interesting topic to cover. So I do have some disclosures. I work for PerkinElmer, a company that manufactures and sells kits for PGT. And I am on the medical scientific advisory boards of the World Egg Bank, Cryos International, and Progenesis. So I get those out of the way. So I think everybody has probably seen this slide a million times. But I think it's important to just think about it. And this is from the CDC SART reporting system that just simply shows that the chances of getting pregnant, staying pregnant, and delivering a live birth, those chances diminish as women in particular age, to the point where by the time you hit 38, 39 years old, your chances of a live birth are somewhere in the 10 to 12% chance. Get a little bit older, up into the 40, 42, your chance of having a live birth is quite low without any intervention. Same goes, obviously, not only getting pregnant, but staying pregnant is difficult, especially as women age, because there's more and more aneuploid embryos. So this is looking at the same data set, looking at the chance of having a miscarriage. And you see that the miscarriage rate's quite low up until about 34, 35, and then that rate just really climbs very quickly after about that 35 to 36-year-old range or the advanced maternal age range. If you look, this is from Jason Franasiak's great paper looking at aneuploidy rates, and instead of doing it by tranches of groups of years, they did it by individual years. And again, you can really see sort of that slow progression up till about 34, 35, and then the precipitous rise in aneuploidy as women age. And so that aneuploidy really gets in the way of getting pregnant, or if you do get pregnant, staying pregnant, obviously having miscarriage. So that then leads us to the hypothesis then of PGT-A, which is that if humans create large numbers of aneuploid embryos, and if anybody doesn't believe that humans do, you can come see me for some more data. I'm going to show you a little bit of data today, but you can come see me for more if you'd like. So if you believe that we make lots of aneuploid embryos, especially as women progress through the age range, and if you believe that aneuploid embryos never become normal live births, and again, we're going to talk about a paper that just came out that shows that point. So if you believe that we make lots of aneuploid embryos and aneuploid embryos don't turn into normal live births, then screening for aneuploidy in all chromosomes during IVF, before embryo transfer, should improve outcomes, right? You should see increased implantation rates, increased live birth rates, and decreased pregnancy loss rates. That's the simple hypothesis of PGT-A. As simply as we can put it, that's the concept behind PGT-A. Now, I find it interesting, having been in this field for a very long time, that we continue to question this technology. And hopefully by the end of this talk, you will at least feel more comfortable understanding the latest data. But the reality is, I think I'd be remiss if I didn't talk a little bit about the history and why we continue to have these questions. The first thing that needs to be understood is that the data to support PGT has been mixed. There were early positive outcomes. Then a couple papers came out and showed little benefit to PGT-A. And then the worst of all things, 11 randomized clinical trials came out and showed no benefit to PGT-A, or actually a detriment. So PGT-A was worse than not doing PGT-A. And so obviously that's not good. Anytime you're going to do a clinical intervention, you're going to cut open embryos, you're going to ask people to pay for that test, you're going to consent them, all those things, obviously you have to have a benefit to it. Now the early data that I'm talking about is from a long time ago, right? It's 1999 to 2008, which is, as we know, quite a while ago. But I still today see people talk about that old data. A new Cochrane review just came out and pulls in a whole bunch of this old data. So this old data will not go away. And I think we have to understand where it comes from and why it was a problem. And then, you know, lastly, all those papers I just mentioned, most of that data was from day 3. So in those clinical trials, there was one paper that was biopsy at trophectoderm with fish. And all that data was based on fish, which we know now isn't the greatest technology in the world. So let's talk about some of the reasons that fish didn't work and why we are where we are today, and think about how we're going to move forward in the future. So in the old days of fish, all those papers I just mentioned that people still bring up, we were testing a limited chromosome set, right? We're testing 8, 10, maybe 12 chromosomes. We are not testing the entire chromosome complement like we can today. So in PGT-A today, we can obviously test all 24 chromosomes. So back in the fish days, an embryo that we said was euploid might have been euploid for 8 chromosomes, but it might have been trisomy 1 or monosomy 2, which is obviously never going to create a normal live birth. There were some serious technical limitations of the method. And if we could be live in a room together, which I wish we were, this is where I usually stop and ask the people to raise their hand and say, are you old enough, like I am, to have actually worked in the fish days? As an embryologist, did you actually spread cells for fish? If you did, you know, number one, how difficult that was, just to get the cells spread and get find the nucleus again. And then it had to come to my laboratory, and we had to find that nucleus a couple of times on a giant glass slide. So not only was it difficult just to get the sample produced and sent to the laboratory and have that part work, then even laboratory doing fish is made for looking at a few hundred cells. Obviously, we only had 1 or 2 cells total to look at. So anything that went wrong with the fish technology, which again is a great technology, but it's not meant for single cells, anything that went wrong with fish could also lead to errant diagnoses. And then lastly, biopsy at day 3. You know, here in the States, I don't know that anybody still does biopsy at day 3. We know for sure that trophectoderm biopsy at day 5, 6, and 7 is definitely better for the embryo. There's some really nice work by Richard Scott's group looking at impact of embryo biopsy on outcome at day 3 and day 5. We also know if you work in a laboratory like I used to and like Nabil still does today, obviously getting 4 or 5 or 6 cells is way easier to deal with than getting a single cell on a slide. So certainly biopsy has gotten much, much better, and that's made this technology much easier to do on our end. So I'm gonna talk through a couple of important data sets that I think are interesting to look at. This is not every single piece of data that's ever been produced. Not all of this is my data. One of these is my paper, but there's some paper from some other groups which I think are really important. And then lastly, I think one of the things I'm going to show is some really, really important information that's been gleaned from the CDC SART data registry, which I think is just incontrovertible that PGT-A clearly works. So we'll get there when we get there. So this is the first paper I want to talk about. This is my paper. This is not an RCT. Let's be realistic. This was just a whole bunch of IVF cycles. This was 2013, so we did look at day 3 and day 5 biopsy. I'm only going to show you the day 5 biopsy work. And I'm going to show it to you just like those charts that we looked at earlier. We're going to look at implantation rate. And in this paper, implantation rate was fetal heartbeat and sac at 20 weeks. So while that's not live birth like we like to measure, it's pretty close. We're going to look at sacs lost or miscarriage, and then we're going to look at the aneuploidy rate, obviously, right? So the first thing I'm going to show you here is the implantation rate across the 4 SART age groups. It's not a perfect thing, but statistically, you can draw a straight line across all four of those age group, or all four of those implantation rates. And so what this paper in the end was able to show us is that if you find euploid embryos up in the higher age ranges, 38 to 40 and 41 to 42, they are just as likely to implant and become a fetal heartbeat in the sac at 20 weeks as they would have been at 30 years old. So again, if you think about the hypothesis of PGT-A, if you transfer euploid embryos, you should see an increase in implantation rate across all age groups. And here in this paper, we were able to show that very nicely. So implantation rate at 41 is not statistically different than the implantation rate at 30 years old. So hypothesis, part of a hypothesis here proven. They're not magic patients, right? That's the green line is the aneuploidy rate rising significantly as patients age. I think it's really important to understand that by the time you get out into 40, 41, 42, the vast majority of your embryos are going to be aneuploid that you're looking at. So you heard me say, hopefully, if you find a euploid embryo out there in those older patients, and that's a real problem, or it's something that needs to be discussed with patients at the very least, is the fact that you might not see, or you might not find a euploid embryo. And then lastly, obviously, miscarriage needs to be looked at. And here you'll see that, again, the miscarriage rate is flat. It doesn't go above 10%. There's an asterisk here. We did not have any miscarriages in the 41 to 42-year-old range. We don't think that we don't think that PGT gets rid of miscarriage at that age range. We just think that nobody had a miscarriage, but other data has shown that that rate would be somewhere around 10%, which is probably the background rate of miscarriage that's not chromosomally induced, right? So while this is not an RCT, in the end, this is about 2,000 IVF cycles with transfer. So it's a very large data set, which is why I show it. The next paper I want to show is from Eric Foreman, using a completely different technology. I love this paper. Notice this paper was published in, I think, 2013. And what this paper is looking at then is single embryo transfer with PGT-A versus double embryo transfer with no testing, right? And so again, 2012, 2013, 2014, certainly we were still transferring more than one embryo generally, and at the time, transfer of 2 embryos was pretty standard in IVF, especially in an older age group, you know? And so the idea here was, can PGT-A with single embryo transfer, can that compete with what was then state-of-the-art double embryo transfer? And so I'm gonna look at a couple of things here. First, we're gonna look at clinical pregnancy rate. That's just the chance of having an implantation. And you'll see 69 versus 81. I haven't done the statistics and I don't remember, but those aren't all that similar. So if you look at just chance of getting pregnant, seems to me that double embryo transfer is at the very least better than single embryo transfer. But when you account for early miscarriages and early pregnancy losses and get out to ongoing pregnancy rate, which again was fetal heartbeat and sac at 20 weeks, you'll see that you've had a bunch of early losses in that double embryo transfer group. By the time you get out to really sustained implantation, there's no statistical difference between transferring a single euploid embryo and transferring 2 embryos. And the point of this study was to show people in the United States, we really should be thinking about more single embryo transfer. And I know that sounds silly perhaps to say in 2020, when I think single embryo transfer is hopefully the norm around this country, but it wasn't the norm 7 or 8 years ago. Let's be realistic. Now, I mentioned that, PGT-A with single embryo transfer isn't better than transferring 2 embryos. It's about the same, which is okay, but it's better in one really important place, which is in multiples. So you'll notice in transferring 2 embryos, nearly half of those patients came home with twins or worse. And twins are not a good thing in an IVF population. Certainly in 36, 37, 38, 40-year-olds, twins are actually pretty bad. I've heard Richard Scott talk about this paper, and there's a follow-on paper, and I've heard Richard say what I think is a great quote, which is, there's no single thing that's ever been done in obstetrics that's better for patients and their children than single embryo transfer in IVF. And this paper, I think, for me, is one of the key papers one needs to look at to see that PGT-A with single embryo transfer is as good as transferring lots of embryos into patients. And it's a lot safer because you're going to cut down on the twins. Now, again, during this study, there were no multiples in the biopsy group. Everybody sitting here watching me knows that if you biopsy enough blastocysts, you're going to get some monozygotic twinning. It's going to happen, but it's never, ever going to reach 48%. I usually quote about 1 to 2% of the time you're going to see twinning in blastocyst biopsy, and maybe it's even lower than that, but it's surely never going to be 48%. So that's, I think, really, really important paper to see. And then this paper I mentioned, this was Ashley Teague's. This is their non-selection study. This, again, the Richard Scott group. This was just presented at ASRM last year, and that's where this data is from. The paper just came out a week or two ago, and I haven't had a chance to update this slide, but essentially the numbers are slightly different. They change by a percentage or two, but the point is the same, so I'm going to keep it as it is.
Gary,
so in case you don't, yeah.
There is a little box that is masking the pictures that you have on the presentation. I'm going to share my presentation, and then you just tell me, and I will move the slides for you.
Yeah, I think it's the box from, let me see if I can, oh, I can't move it. I've got my other screen shut down.
Okay.
Oh, here, I can do this. Nabil, is that better?
I am putting the presentation right now. Maybe you could just tell me, and then I will move the slides for you.
Yeah, sure. And I saw that it was Don. Don, is that better now? Can you just put a chat in there? Because it looked fine on my slide.
Yeah, I think it looks good.
Is that better?
Yes.
Okay. Yep, that's good. Sorry, guys, I didn't realize. So this is Ashley Teague's. She presented this at ASRM. In case you're not aware, non-selection study, the way it works is all embryos in the study are biopsied and tested by PGT-A. However, the genetic testing data is not used to aid in embryo selection. Embryo selection is done conventional, look down the microscope. Embryologist chooses the best embryo, whether it's aneuploid or euploid, they have no idea. They transfer those embryos, and then once the patient's pregnant, you go back and look and unlock the data, and you see what happens, right? So what we're going to do here is we're going to look first at what happened when they transferred a euploid embryo. So when they transferred a euploid embryo, they saw 81% implantation rate, so positive beta HCG. They had a 69.2% fetal heart rate, so fetal heart and sac. And then delivery, so again, here we got the delivery, 64.9% of the time that you transfer a euploid embryo, you had a delivery of a baby. Can you hit the next slide, Nabil?
You have the control now.
Oh, I do, okay. Oops. There we go. Okay, so then when they went back and unlocked the data from the aneuploid embryos that were transferred, what they got was a 41.7%. Hold on, guys. Sorry, we're having some technical issues here. Can you, Nabil, can you go back one slide? I don't know why. There we go. I don't know why it went forward. So here, 41.7% implantation, 20.8% had a fetal heartbeat and sac, but that line is a little bit off. It should be 0%. So in this study, with, I think it's in the paper, I think it's over 200 transfers, 0% of the time that you transfer an aneuploid embryo, did you get a live birth, okay? So remember back to that hypothesis of PGT-A is if we create lots of aneuploid embryos, and aneuploid embryos are never destined to create live births, here's the data that I use to support that statement, then PGT-A is working. And so here you see, transferring a euploid embryo, you have a 65% chance of a live birth. Transfer an aneuploid embryo, it's a 0% chance of live birth during the time of this study. So I think this is, for me, this is a very, very powerful data set to look at. And as I said, I wish I had the new data. The numbers are about the same, and the story is the same. So congratulations to Ashley and the group, Richard Scott's group. Let's see if I can. There we go. Okay, so this is unpublished. This is from, I think most everybody on the call hopefully knows Dave McCullough. So I have to give Dave a big shout out for number one, doing all this work, and number two, sharing this data with me. So this is from the US CDC SART data registry. It encompasses 2014, 2015, 2016, 2017. This is looking at live births per embryo transferred. So multiple embryos get transferred here. But the key to this one for me is this is looking at 451,000 embryos transferred in those 4 years. So this is not an inconsequential amount of data. Now again, not a randomized clinical trial, but no RCT is ever going to look at over 450,000 embryo transfers, right? So it's 118,684 with PGT, 332,750 without PGT. Now notice I don't say PGT-A there. In the SART database, it only says if the embryo got biopsied on. It doesn't say if it got PGT-A. So we'll just presume that no matter why it got biopsied, it had PGT-A, right? Because if it was PGT-SR or PGT-M, most people still do PGT-A along with it, right? So we're going to look at the typical age groups. And the first thing we're going to do is we're going to look at the chance of a live birth based on embryo transfers without any intervention. So no biopsy, no PGT-A. And you see chance of live birth, not surprisingly, under 35 is just under 40%. It drops down to somewhere below 10%. I'm going to guess that's about 3 or 4%. And listen, in that over 42, that's 30,702 embryos transferred over those 4 years. So it's really hard for me to say that this data is not really strong. That's a lot of data points right there. And you can see that chart doing exactly what you would predict based on the 2 charts I showed at the very beginning, which is the chance of a live birth drops precipitously as patients age. Now, if I uncover what happens with biopsy, so PGD, PGS, or PGT of some sort, you'll notice a couple of things. One, very high live birth rates across all age groups. It does drop a little bit in that over 42, but it's significantly higher in every single age group. So in a data set with 451,000 embryos transferred, PGT-A or PGT, biopsy and transfer of euploid embryos, is better than transferring embryos blindly, no matter what age group, no matter what you do. Very, very strong evidence. And it's impossible, as far as I can tell, and somebody can correct me if you think I'm wrong, it would be impossible to manipulate this data and make it look like anything more than it looks like this, right? So I think this is really strong, and I commend Dave for doing this because this had to have been a ton of work. Now we can look at the same thing for miscarriage by age, right? This should have the opposite track that the implantation rate or pregnancy rate has. This is miscarriage by age, same data set. You notice that under 35, it's right around 10% for both. There's no difference. But once you get 35 to 37, there's a significant difference, significantly lower chance of miscarriage with biopsy than without biopsy. So again, the point of PGT-A is to get patients pregnant and keep them pregnant. And so again, really, really powerful data, I think. Now, one of the slides that Dave has that I don't have in here does look at the chance of not getting a transfer. And that's really important. Patients have to understand that there are times they're not going to get a transfer. Now, it's interesting how many patients in the upper age groups that don't do PGT still don't get a transfer. At least it was interesting to me. It's always higher with PGT-A, but it's not inconsequentially negative or zero without PGT-A either. So again, I think it's a counseling point. There's pros and cons to the test, and patients have to be made aware of those pros and cons. So just to wrap up this portion, yeah, sorry, Don, I'll get back to that in a second. Early ambiguous data on chromosome screening was most likely due to poor study design, flawed FISH technology, and perhaps moment of biopsy, mosaicism. PGT-A allows for analysis of 24 chromosome aneuploidy in fresh and frozen samples. PGT-A leads to high implantation rates across all age groups, and biopsy with chromosome screening should allow for routine single embryo transfer in all patient populations, no matter maternal age or reason for IVF referral. So that's sort of where I land after that little part of the section. You can argue with me if you'd like, but that's how I feel about PGT-A. For me, PGT-A is a really powerful technology. It's not the right choice in every single IVF cycle, but I think patients need to understand the pros and cons of doing testing and deciding whether they want to do PGT-A or not. Now, with the last few minutes, I just want to cover mosaicism because I think for me, it's still a really hot topic in the field. I think it's a topic that we in the genetic side don't really do a very good job of explaining to our customers and perhaps patients about what a mosaic call means and what that might mean down the road for the patient. So we're going to just cover mosaics. So obviously, you know, we used to have euploid embryos and aneuploid embryos, what I like to call the good old days, when our life was easy, when there was just two options, yes or no, green or red. Now today, of course, we have mosaic embryos, which do create a little bit of a gray area. And it should be noted that unlike aneuploidy, mosaicism doesn't seem to be age-related. It's mitotic error. It happens across the board. It happens in all age groups, right? And so it's a mitotic error, so I think it's good to understand how this happens. So you can have two perfectly good gametes that come together to make an embryo, and then if you have no mitotic errors, you're going to get a uniformly euploid embryo. If, on the other hand, you have a mitotic error, let's say you have a mitotic error very early on the second division, then every cell that comes from that division is going to be one of two things. It's going to be a gain or a loss, and therefore, obviously, the embryo becomes very, very aneuploid. And the aneuploid cells might actually take over and be 100% aneuploid or 50% mosaic. If it happens one division later, then obviously you're going to have less mosaicism. And if I could draw more circles and more arrows, you can see how you can get these things confined in just one little place in the trophectoderm. Because obviously, you know, an embryo goes from day 3 with 8 cells to day 5 or 6 with somewhere near 100 cells. So it goes from doubling its cell number once every 24 hours to doubling its cell number every 3 or 4 times a day. So lots of mitoses, lots of chances for a miss. And every time a mitotic, the later a mitotic error happens, then the more confined within the embryo that mitotic error is going to be. And obviously you could have a mitotic error or meiotic aneuploidy and get a completely aneuploid embryo, right? So either from gametes or in the first division, if you get the first division isn't right, then you're going to have uniformly aneuploid embryos. And there's all kinds of ways to chop this up. But my point of this slide really is not to get into the whole concept of where these embryos come from, but the fact that mosaicism can be really confined to just a few cells within the embryo, which is why it's so difficult. And it really is confounding to everyone that has to look at the results. Okay, so I think the thing that we don't do enough explaining around is threshold modeling, right? So where do you set your thresholds for mosaicism? This laboratory might say it's 30 and 70%. So anything below 30 is euploid, anything over 70 is aneuploid, and anything between 30 and 70 is mosaic. And that might be perfectly reasonable, right? So you would draw a box around those numbers. You can see those numbers in column 3. Copy number value, they correspond to the gain side of the chart on the left side. So this is some cell mixing experiments we did in our own laboratory to understand mosaicism. So if you have 30 and 70%, then your mosaic box looks like that red box that's on the left-hand chart there. You can see that it encompasses the 30% mosaic all the way up to the 70%. Now, another lab might say, well, I think 80-20 is better, right? Now your mosaic box just got bigger. So it's hard to understand if you send one sample to lab A and another sample to lab B, if they have different mosaicism calling thresholds, they may give you a different answer. It doesn't mean that either lab got it wrong. It just means that their mosaicism thresholds are different. And I think it's really important on the end user side as a lab embryologist or nurse or clinician ordering the test, I think it's really important to speak with your laboratory to make sure you understand how they're calling mosaicism and what is and what isn't mosaic. So another way to look at this then, this is the same exact chart, same exact data, just blown up a little bit. And so simply put, if you have a call, it can be any one of 3 things. It can be mosaic, these lines moved. Obviously that mosaic box should be a little bit higher. I'm not sure why it did that, but you know, you're going to get one of three things: a euploid call, mosaic call, or an aneuploid call. So just imagine, everybody, that those three colored boxes are a little bit higher. And that gray box in the middle will change size depending on how your reference laboratory calls mosaicism. And I think it's really critically important to understand that. There's some really nice data. I'm not going to go through this too hard, but there's some really nice data around transferring mosaic embryos by a number of groups. This is from the Spinella group, Francesco Fiorentino's group in Rome. They were the first ones out really transferring mosaic embryos. I think this is quite interesting. In this paper, they looked at low level, under 50% versus high level, and saw that there's no significant difference between a euploid embryo and a low level mosaic embryo, but there's a significant difference between both of those and high level mosaics. So I think that's really important to understand and read that paper. There's some other papers. The group at Zuvez, Andrea Victor, has a really nice paper on transferring embryos. And there's a really large data set of just over 800 mosaic transfers that's in press. It should be published soon. That will be the largest data set to really look at what happens when you transfer mosaic embryos. There are some guidelines. I'm not going to read this to you. This is from PGT-A. I think the key here is that it's a gradient of risk. The gradient of risk is the higher percentage of mosaicism is more risky than lower percentage, we think. And depending on which chromosome it is, can be more risk or less risk, right? And so I think it's important for anybody that's transferring mosaic embryos, you should definitely read this paper, which is readily available online. And then the genetic counseling SIG at ASRM just came out with a practice guideline paper that is fantastic. And I've got 2 slides here, or 3 slides, but everyone should go read that. I do want to point this out in my last few minutes here. I know I'm going a little bit long because we had that little technical glitch. There is a paper that just came out from Semra Kamaran in Turkey, Istanbul, where they transferred in a 39-year-old. They had 1 embryo. It was mosaic monosomy 2. 35% mosaicism percentage is what the lab recommend, or what the lab called it. They counseled the patient. They transferred the patient. She got pregnant, and at amniocentesis, the amnio showed a mosaic trisomy 2 in 2% of the cells that were screened out of 100. In quotes, healthy baby girl was born at 37 weeks gestation. The peripheral blood on that baby showed 2% mosaic monosomy 2. So this is the first data report of a known mosaic embryo being transferred and an actual mosaic child being born. Now we'll have to see, they've only looked at peripheral blood. They haven't looked at other tissues. They haven't looked at the gametes. This is really, really interesting to follow. And this is the first report. I'm sure this is not the last report of an actual mosaic child being born. So as I mentioned, this is the work by the PGT, the genetic counseling SIG. I'm going to skip through those slides really quickly, but that paper is available on FERT and STIRT today. You should definitely have a look at that if you're transferring mosaic embryos. For me, the last thing I want to say is we still don't really understand how many embryos are truly mosaic. We don't understand how the biopsy marries up to the inner cell mass. We have some data. Again, Andrea Victor's done a really nice look at that. There's some other work that was done early looking at trophectoderm versus inner cell mass. How the biopsy marries up to the fetus is a question. Are we creating some of this mosaicism? Is, growing embryos, culture, biopsy, shipping, all the things that we do today, is that creating mosaic results? And then everyone says normal live birth. And I put that in quotes all the time because very few people have done what the Kamaran group did and really looked to see if that kid was mosaic or not. And I think we need to do more follow-up on these babies. And then lastly, I know Nabil talked about non-invasive. I'm super excited about non-invasive. I think it's going to be a real move forward in the field, and I'm super excited about it. So thank you very much for your time. I'm sorry I went over. I'm sorry about that little glitch on the slides. But with that, I'll finish up and I'll be back for Q&A.